Okay, so this is a very long topic, so it's impossible to cover in 15 minutes, but we'll give it a good try. So, big and ugly ASD, multiple defects, no IVC access, and pulmonary hypertension. I changed it. I put pulmonary hypertension in the end because I hate pulmonary hypertension. So, the less amount of time you spend there, better off we're going to be. Okay. So I made this. How do you define big ASD? Then how you define the big and ugly ASD. I guess big ASD, any ASD with a diameter of 25 millimeter, you can safely say is a big ASD. Really big, maybe 30 millimeters. When you go to pediatric patients, I mean, there are patients I have close who are 2 or 3 kilograms. So if the ASD diameter is more than 1.5 or closer to 2 kilograms per millimeter, that's a very, very large ASD. So for example, a 5 kilogram patient, if he has an 8 or 10 millimeter ASD, that's a huge ASD to close because the left atrium is going to be very, very small. It'll be very difficult for you to accommodate the left disc and the right disc, whatever device you're choosing. And same thing goes on for 15 to 30 kilogram patients, where if it's 30 millimeter diameter ASD, that's going to be big. And if the patient is above 30, you can treat that patient as an adult. So what's an ugly ASD? Well, that's a tough question. So in my opinion, an ugly ASD will have multiple deficient rims or absent rims. So we know aortic rim can be absent or deficient in 50% for sure, sometimes 80% of the patients. But if you have aortic rim deficiency and you have posterior or atrioventricular valve or superior or IVC rim deficiency, in addition to aortic rim deficiency, you will have a harder time in placing device accurately. If the defect is very eccentric, so if posterior superiorly located or posterior inferiorly located, that will be a difficult defect to close, especially if it is large as well. If it's significantly oval, I didn't make these numbers up. I have seen ASDs that measure 15 by 25. They are very difficult ASDs and may not be technically difficult, but they are difficult because how would you size them? If you balloon size them, they are going to be about 20. But 20 millimeter defect is going to be much bigger for the 15 diameter and smaller for the 25 diameter. If it's dynamic ASD, dynamic you will see sometime in pediatric population where the ASD may measure 7 or 8 millimeters, and during atrial diastole suddenly it's 18 or 20 millimeters in diameter. So it literally the septum expands or the ASD expands and shrinks with every atrial systole. So that's a difficult ASD to measure properly. So for me, that's an ugly ASD. And finally, I think the most difficult ASDs are these very thin, fluttering atrial septal defects, because most of the time they're always more than 1, 2, 3, 4, 5, and so there's a very good chance you're going to miss 1 or 2 of those. So careful analysis in these patients is important. Now, I'm going to go very, very quickly. I think all of you guys are expert, and if you don't know how to close ASD, so you're really starting today then. So anyway, for simplest way to do the ASD, I think if we put that in our mind, that there is one thing you have to do, one thing you have to do, and I teach that to all of my fellows. Remember, if the sheath is like this in a complicated ASD, it's a no-no. Sheath has to be parallel to the spine in AP view. And then you have essentially conquered the Hausdorff sheath and every sheath, because that's exactly what every sheath that you are going to use does. Nothing else. It does nothing else. Remember, this is a no-no in a large ASD. It has to be like this. The moment it goes straight, parallel to the spine, you are almost there. I promise you, most of the time, you will never have to use anything else. So clockwise rotation of the sheath exactly does the same. You're like this. You're going to rotate it clockwise in AP view. So the curve goes backwards, and you lose the curve in fluoro. Okay? Left upper pulmonary vein technique is not this technique, but at least you're going very posterior, because the left upper pulmonary vein is way posterior in the recess. So if you're in the left upper pulmonary vein, you're going to come from way behind and slap the septum. So this left disc is going to be parallel to the septum, and guess what? You're going to be able to do it. Roof technique, left atrial roof technique, or the right upper pulmonary vein technique does exactly the same. It's just slightly more clockwise rotation. So remember, everything you are doing is essentially straightening this delivery sheath parallel to the spine in AP, not the LAO, remember that. Okay, and then there are many other ways, dilators and balloons and all that stuff. So this is the Hausdorff sheath, and if you notice, this is house of sheath on the right side. This is not an angiogram or a fluoro, live fluoro I mean. See how straight the house of sheath that made the house of sheath, how straight it is as compared with the spine. That's all what you really need to do. If you can do that with any sheath, you will have very little problem. Couple of things, when you're rotating the sheath clockwise, it happens a lot. We have a very bad habit that we go far away from the groin and rotate it. No. It's not happening. You're here at the tip, and you have the tip, and you have to put the second hand at the close to the groin. And don't do static rotation. Don't rotate like this, because you may not transfer this torque from outside to the tip of the sheath. So what you're going to do is you're going to maybe advance or pull, whichever way, depending on the depth of the sheath. Pull, and then while you're advancing the sheath, you rotate. So do both movements simultaneously. Not rotate and advance, not advance and rotate. Do simultaneously. When you do simultaneously, you're going to be able to propagate the torque from the groin all the way to the tip. And that's what you want. You want the tip of the sheath to rotate, not outside rotation. So here's a picture. This is a very, very small child, and you can see this is a very, very ugly angle here. And the device is going to pop out. So what you're going to do, if it runs, all right, let's keep going. What you're going to do is you do just clockwise rotation. This is the same case. Clockwise rotation is slightly parallel, not completely parallel, because the left atrium is so small, it would not accommodate the left disc completely. So the moment you are very close to the septum, you have now started deploying the right atrial disc. And by the time you get there, you are finished there. The same thing happens if you were used to use ICE catheter. I don't know why I do this, but some of these pictures are not running very well. Same thing happened exactly if you were using intracardiac echo. This is a big and ugly SD. Fenestrated atrial septal defect, as you can see thin area in the four chamber view, you can see in the short axis view, and you can see with color the same pictures on the right side. We did balloon sizing here. I usually never balloon size. In this particular case, I did balloon sizing because it was fenestrated ASD to get what kind of oomph that fenestrated septum has. And then, if you notice, we place the device very, very deep. You can see actually the device coming. We use maybe less than a minute of fluoro at the most, and we were able to do the case. Again, remember, if the device disc has to be parallel to the atrial septum, no matter which way you do it. Always remember, once you have done the device, always look at the AV valve, especially if it's a large ASD in a smaller child. Always look at the mitral valve. Left disc is bigger. People, if you don't look at it very carefully, you may impinge on the mitral valve, and that's an absolute no-no. I would send the patient in a heartbeat to a surgeon than to impinge on the mitral valve. Okay, Dr. Benson presented and actually reported left upper pulmonary main technique 15 years ago, I guess, or so. We did it about the same time as well. Very, very simple technique. You want to put the sheath inside the left upper pulmonary vein. Put part of the device out. If it becomes like a green onion, you're okay. If it stays straight, you're too deep. Okay, so test it out. So then pull back the sheath or advance the sheath accordingly. Then what you have to do is very rapidly. You have to pull the whole sheath back all the way to the IVC. What it does is it is going to give the device enough time to come out of the pulmonary vein and slap the atrial septum. So if this were to run, you see how fast it was? I used to call it 5-second technique. Very, very quick. Boom, and it's done. Again, check the mitral valve. It's a large ASD. Check the mitral valve. Okay, this is how it should look on fluoro. Now, when you're doing this, if the device is stuck, the natural instinct is you pull. Don't pull. Push it forward. If you push it, it comes out a lot easier actually. If you don't pull on it, push it. If it's too deep, recapture it. But if you know it's going to come out, don't pull on this, just push it, and it's going to flip back much easier. Roof technique is very, very easy. Again, the whole idea is what the Hausdorff sheath is going to do to you. Okay, keep it parallel to the spine. I want to stay on time. And this is a cartoon of it. You are going to keep the catheter here, deploy the device. When it comes out, it's to snug the roof of the left atrium. Keep it pushed. Keep it pushed there with the cable while you pull the sheath back. The difference between the left upper and the left atrial roof technique is in the left upper pulmonary vein technique, you keep the cable taut. In the left atrial roof technique, you keep the cable pushed in. That's the only difference between these two techniques. I'm going to bypass that one too. These are a lot of other techniques, like I told you. I'll show you Bharat Dalvi's picture. People use this a lot, actually, believe it or not, outside the country, this balloon-assisted technique, but I think they always used it in the wrong way. So I want to show you the way he described it, and I think that's the best way. You have the sheath in the right upper pulmonary vein, then you put this balloon, inflate the balloon, and then you, let's see if this runs. They're running on my computer. Well, anyway, then you start deploying the device when the edge of the device is kept into the left atrium. So this balloon is in the left atrium. So the left anterior edge of the device is kept into the left atrium while you deploy the whole device. Once the right disc is deployed, you deflate the balloon. Now, moving on to the multiple atrial septal defects, people used to say if the defect is 7 millimeter or large away from the second defect, you have to use two devices. May not be true. You know, 4 through 10 millimeter AST devices are 6 millimeter larger, the left disc. 11 through 32 is 7 millimeter. 34 through 40 is 40 millimeter larger. So I think it all depends how your left disc sits. So put the left disc first, and then see if you need to put a second device in or not. But if you are going to approach it, always have a bilateral femoral venous approach, okay? Balloon size a defect, and when the balloon is inflated, go to the second defect. A lot of time you will have harder time going through the second defect because the catheter angle is such that it loves to continue to go through the same defect. How long do I have?
Yeah,
you sure?
Plenty of time.
Okay. So now there are a lot of techniques. If you talk to people, they will say deploy the smaller device and then wedge with the larger, interdigitate the device. There are so many ways of doing it. You choose what the best way of doing this is. The objective is that you want to close all the defects possible, especially if the patient has had stroke or something like this. This is a patient with multiple thin aneurysmal septum like you were discussing about. And if you can see here, the patient has a lot of holes. So there is no way you can put one device and you will assume that all of these defects are closed. Okay, so this is a patient who will need multiple devices. This is a patient who will need multiple accesses, at least two. So you go through one, measure it, size it, then you go through the second one. Okay. Now, one of the techniques I want to make sure I show with you. So let's say you go through one of the defects and now you have pulled the sheath back, and then you have to recross it. It's very, very important that how do you recross this through, you go to the larger defect. Because if the defect is posterior inferior, you will 100% of the time will go almost 100% through that defect, never to the larger defect. So one thing we do is if the sheath has come out, I'll put a wedge catheter through the sheath, inflate the balloon in the right atrium. Now it's about 12 millimeter at least, right? So you know you will not be able to go through a smaller defect. Then you advance the whole ensemble or system or whatever, and you will cross the larger defect, and it's safer because the sheath is much stiffer and uglier the tip, right? Now you have a balloon at the tip. So this is actually, you see, this is a delivery sheath, this is a balloon. So we went through the wedge catheter, inflated the balloon in the right atrium, and then advanced it, and we were able to cross it without injuring the atrial septum and easily through the larger defect. Multifenestrator ASD, maybe you can send these patients sometime to surgeon. It's okay. It's okay to give them one of too few cases. Okay, there is no harm in doing that. Some cases like this is Felix Berger's very, very nice paper. This is the atrial septum. You definitely don't want to close. You don't want to put 7 devices or 8 or 10 devices.
Just put one there, one
Yeah.
there.
Or or you can give it a good try. Okay. So the whole idea behind this is the left disc, the right disc, how much of this can be sandwiched, right? So nothing special about it. So this is a technique of multiple ASDs. You can deploy the smaller disc first, then the larger disc first, all the stuff. Now, the word of caution from my perspective is do not oversize one device significantly to cover every defect. There is absolutely no reason to. If it is expensive, send him to surgery. But don't oversize and make it look uglier to cover other defects. One bad thing you can do is you can tear the atrial septum by putting a really large device, and you think the patient is safe, and 8 hours later, the device could have embolized. Okay? So quickly, sorry about that. So this this thing you see in the lab now, let's talk about no IVC access. So sometime you see a patient who has azygous continuation, sometimes you see left SVC, IVC or hemiazygous continuation. What are you going to do in these patients? Okay. So one thing, people like to come from the neck sometime. It's workable, it's doable, it's very, very difficult. The reason is I tilted this to simulate like if you were coming from the neck. The septum is away from you. The sheath has to go this way. The disc is not going to be parallel to the septum. It's going to give you a hard time. You will jump into the left ventricle several times. You can injure the mitral valve. One of the ways to do that is put the wire into the right upper pulmonary vein or the right lower pulmonary vein, advance the sheath there, and then try to come that way. But it doesn't seem to work very well. To me, the transhepatic access is fantastic. Fantastic. I've done maybe 20 plus cases of ASDs along with this. Okay, you can use a NEF set made by Cook. You can use Boston Scientific mini stick set. Okay, it's such a simple procedure you would not believe. You have to outline where you are going to go. You have to give good amount of lidocaine all the way to the liver capsule. Okay, so I'll tell you. So what you're going to do is you're going to go to the middle, do a quick fluoro, go in the middle of it and mid to anterior axillary line and point towards the shoulder. Okay, point towards the shoulder. So when you're getting there, for example, this is one of my cases, very small vein, but I was able to do that. Once you're there and you start injecting, there are three scenarios that can happen. When you inject, contrast stays there. So you mean you're in the liver parenchyma. When you inject, the contrast goes towards the liver, mean you're in one of the hepatic arteries. When you inject, the contrast goes towards the right atrium, you're in the hepatic vein. That's where you want to go. Advance your wire and then do it. So this is a patient where I close an ASD in a patient, PFO actually. And then almost always I use it. A lot of people don't use it. I always put a coil or a AVP1 or AVP2 or something like that to close it. Should we finish? You sure?
Yeah.
Okay, so this is very, very simple. Absolutely all of you guys, especially the pediatric group here, absolutely know pressures and resistances. I think pressure is a guy, resistance is a lady. That's life. So, but they have to work together, okay, to be harmonious. Okay, so right heart catheterization absolutely positively plays a very, very vital role in patient selection. You know, we all know this, okay? So right heart catheterization, you have to do SVC SAT for my adult colleagues. Few, if you don't do it, you have to do pulmonary arterial SAT, you have to calculate QPQS. Always remember this acronym, a SLAP. The simplest way, if you forget, not the pediatric guys. A for aorta, S for SVC, LA, or pulmonary vein, LA, and P for pulmonary artery. A minus S, LA minus P, divided by LA minus P will give you a rough QPQS, right? So remember the acronym, a SLAP. So I can finish my talk after this slide if I have to. I don't want to give you data. So in my humble opinion, ASD closure is indicated for all asymptomatic and symptomatic patient with a net left to right shunt. Nobody will ever argue with that, okay? If the PVR is less than 10, now you can argue with that. That's why I put that in red. People will say 7. Okay, some people will say 6 because they have seen bad thing, okay? But in general, if the PVR is less than 10 Woods units and the resting O2 SATs are above 90, if the patient walks in his SATs at 88%, you have to worry. Should I really close this ASD? Never ever close ASD in patients who have Eisenmenger pathology, I would say. And usually the PVR, if it's 15 or above, absolute no-no. Patients with the PVR between 10 to 15, you can put them on anticongestive therapy, make them feel better, bring them back in 6 months or so, and see what the QPQS is, and then close it. You can use fenestrator device. We used this in 2002, first time ever. I'll be honest with you, there's no data that it helps you, but it protects you from significant pulmonary hypertension crisis. I think I should stop here. It's taken a lot of time. Thank you very much. So.
That was terrific. I guess we have time for one question. John?
Yes.
So one of the things that, this was back in, I guess, 2000 or so, we noticed when Craig Fleischman was with us in Orlando, one of the things we noticed, Craig Fleischman was doing a lot of our imaging in the interventional lab, and we noticed that when he put the TE probe down, and it's not just in small children, and you have the device, or you're trying to seat the device, the ASO, you know, it always, the LA disc went like this. Every time it goes up, down to the stomach, the LA disc turns like this, turns. And a lot of times people were having a hard time getting the LA disc correct, despite all the maneuvers you were showing. And it was clear that think about it, the esophagus is right behind the left atrium. The left atrium is not that big and fairly big ASDs and little kids, so the disc doesn't have room, and with the stiffness of the TE probe against it, it can't. It's not the wall where it can kind of move things, and it. Well, and Craig, you know, I said, hey, do that again. Look at this thing. So what we did from that was I typically, unless you're using ice, which that doesn't happen, is I typically always have the TE probe up. I don't deploy with the TE probe, not in small kids with big ASDs, and even it does it even in big patients too with big ASDs. And just because you can tell to me, I can tell in LAO cranial to get the proper view how the disc comes out correctly or not, because sometimes the TE, particularly in small children, is not your friend when you're trying to close an ASD. And we close a lot of little tiny kids when we're talking about ASD. So I don't think TE probe, personally, I think it can work against you when you're trying to do ASD very good size in small kids.
I completely agree with you, and I've seen that. We use ice catheter sometimes, actually. In the smaller babies, 2-3 kilo, we use ice catheter. Actually, it's much simpler to put through in the esophagus and then do close ASDs as well. Okay.
Does anyone have, this is a great opportunity, I think we can take one or two more questions. Does anyone have, if you've ever had a problem with an ASD and you didn't understand what's going on, it's a great time to ask. There's a lot of people who know a lot about this in the room. So if you can think of something, or if you want to approach Zahid later, or John, or Lee, or me, Sammy, who's sitting in the back, is just putting together 1,700 ASDs that we've done, and we're doing our long-term follow-up right now. Any questions? I'll ask one question. In fenestrated septums where there's multiple defects, do a balloon septostomy. You may hate that. I do a balloon septostomy, and I make one big defect, and I put in one big device. Have you done that at all, or not really? Or
So it's yes, yeah. I've done it in the early part of my career. So I did that a few times when we were defects were far away. We tried to do septostomy toward the septum in between, and then chose a bigger device. Yes, so it's an option.
So before the cribiform, Matt and I were just talking about this. Before the cribiform, I spent 2 years convinced Kurt to make such a device, and he always would say bullshit, it'll be like leaking cardio seals, because it's non-self-centered device. And so we did exactly, we didn't do septostomy, but we did static balloon through one of the fenestrations and decided to do the next one, because we knew we had a device big enough so we could close it. The worst thing to do is to make a closable defect into a non-closable defect.
agree?
Correct? So I'm trying to do the balloon septostomy. We did static balloons back before then. And then once, we convinced him to make the cribiform, which actually started out as a reverse 35 millimeter PFO, because he didn't do it, he just put the screw on the other side when we first started in 2000. So with non-self-centering devices, whether it's the bore or whatever, but the problem was we had larger cribiform molds made, but AGA fell apart. There was 40 and so because you need, as you know, in some of the big ones, it's not long enough to catch the rim. The 35 is not quite long enough.
So the question is, when you have a dominant defect, that's 15, and then you have 4 other fenestrations. What size defect are you comfortable putting a cribiform device in?
In the original cribiform trial, we were the site. We were in Orlando at the time. There were almost 20% of patients had 2 devices. And the crib could have an ASO, and the ASO closing the predominant, and then the cribiform, we'd go through the middle of the cribiform. Yeah. So about 20-some odd percent had 2 devices during the original trial.
Just as a comment for what John had mentioned about TE echo or not looking at the echo and doing a fluoroscopy, I think one thing that's really important when you close ASDs is always do it the same way. Always do it the same way. always use the same projection so that when you put the device in and you look at it on fluoroscopy, you know it's in the right spot, or you don't, or something's wrong. Particularly the anterior rim. I've seen cases where we're done with TE, and they spent a long time trying to figure out that the patient was in the right spot, that it was an odd orientation, and they finally decided that everything was okay. They released it, patient went home, came back with a embolized device. And when you looked at the fluoroscopy, you could see that the superior margin of the device sort of had a wavy line, and you know that's not in the right spot. You just know it's not in the right spot because it doesn't look like every ASD that you close every time, because they all look the same in the LAO cranial. And you know, whether you implant it in a slight LAO or slight LAO cranial, at the end of the procedure, always go to the 30-30, and you should be able to see the device exactly the way you have it in your mind's eye. And if it's not like that, it's not in the right spot. Doesn't matter what the echo shows. It's not in the right spot. So, you know, certainly what I try to do when I do it with the fellows, the steps that we do are always exactly the same. So you know if there's any deviation, something's not right that you have to figure out.
Yes.
So, a couple of questions that have to do with each other. The first, and I don't know if I heard you right, did you say you normally don't balloon size ASDs?
Oh, God. Yes, I do not balloon size. I balloon size every PFO. I don't balloon size ASDs unless for a couple of case scenarios. If it's a very thin aneurysmal septum, I will balloon size. If there is clearly evidence of two defects, I'll balloon size. But if the defect is a single defect, especially in children, I will not balloon size, because you can make a defect that is easily closable, not closable, by doing balloon sizing and making it so big that you start thinking, I cannot close this defect. So we can have a war zone here. So, you know, you literally asked the question, which I probably should have abstained from saying that sentence. I don't balloon size. So, you know, I mean, there are many people who are like me who don't balloon size. There are fantastic people sitting here. They always balloon size. I think the best thing is what you feel comfortable with.
So you base it off a static TE?
So I base it off of transesophageal or intracardiac echo in 3 views. There is no way I will not do any ASD without looking in 3 views: 4-chamber, short axis, and bicable view. And then we get the average diameter. If we see a very thin septum, so let's backtrack. Balloon sizing is going to do two things for you, right? One, it's going to rule out if there is a second defect, right? If you balloon size one and you still see shunt, so there is a second defect. Good. Second, it is going to give you an average diameter of the defect, right? Average diameter defect plus all the thin septum that a device disc can fold away. If you were using a self-centering device, it will give that to you, depending upon how much you inflate, right? So if I can measure the defect in 3 dimensions to get an average, and if I can have a thin septum, which I know when I balloon size is going to fold away, and that's like 2 or 3 millimeters, so I will add that to the average diameter, and I'll do it. I have had a fairly good success with it.
The 3D image typically will give you, I wouldn't have said average, it typically gives you the maximal diameter of the elliptical shape is what you're trying to obtain with your balloon size that the stuff floating on you. And that measurement on your 3D, from I balloon size every case because it's crank here. But you know, if you look at your balloon size compared to the 3D image, it's the longest diameter that seems to match closest
That's true.
to the balloon sizing, so that many people who use 3D on a regular basis tell me that's the diameter that they use when they're not going to balloon size, because it seems to come closer to that approximation of what balloon sizing gives you.
It's an excellent point. And also remember, the way as a learning part is, every time you put the device in, measure the waist. Measure the waist. If it is pinched, you know you oversized it, right? So you'll know what you'll do in the future. I always used to measure the waist after I put it in, how much. You know, if I measure defect 18, and let's say you put a 22 millimeter device, and now the waist is 16, you know it's significantly oversized, right? So you can then rearrange your mental setup for the next case with that. One thing I wanted to, before we finish, is be aware of the eustachian valve. I know I didn't talk about it, but that can really mess up the situation sometime if it's a very, very long eustachian valve. People may not even recognize sometime where the true defect is, where the defect, because where the eustachian valve is. Thank you so much.
You know.